for taking time out to join this meeting tonight. My name is Anne, and I'm the unit manager of the Medical Surgical Unit. I've called upon each of you tonight to discuss a never event that occurred in my department. I hope all of you had the chance to read the email I sent regarding the meeting's agenda. I want to take a time out first to introduce all of ourselves, then we're going to review the case study, discuss and examine the case, and lastly, we are going to recap. So, my name is Anne. I am the unit manager for the Med-Surg unit. I oversee all the operating aspects of the unit, from supervising nurses to monitoring patient care. I would like to establish some certain policies and procedures so this never event will not reoccur.
My name is Joe. I'm from Risk Management. I'm here in this meeting today to try to aid in our solution to prevent further never events happening in the hospital, reducing the hospital's amount of liability and increasing patient safety regarding these issues. Today I think we should look at what led to the mistakes, what things we can do to correct the mistakes in the future, and also begin collecting information towards finding out where we've made mistakes in the past and how well we're doing moving forward.
My name is Tracy. I am the clinical nurse lead here on the Med-Surg unit, and I would like to see how we can focus on making a collaborative effort to assist the bedside nursing staff with trying to assist in their contribution to preventing these never events from happening and occurring again.
My name is Brenna. I'm the informatics specialist. My goal is to review and update the electronic documentation and improve clinical outcomes by more user-friendly computer interface. So hopefully by reviewing the medical records, I could contribute to figuring out where this mistake went wrong and how we can improve to not anymore in the future.
Okay, thank you, everyone. Now, the purpose of this meeting is to discuss a never event that occurred in the medical surgical department during a thoracentesis. The error was not identified until after the initiation of the procedure when the physician attempted to evacuate fluid from the pleural space. Now, the goal of this meeting is we must ensure that we have enough information to establish an effective plan of action to prevent the recurrence of this never event and to submit this to the Quality Informatics Committee for review. Let me go ahead and share the case with you now. This case involves a 65-year-old male who was admitted to the medical surgical floor for pneumonia. During his stay, the patient started to complain of increased shortness of breath. The primary nurse noted patient to be in respiratory distress with decreased breath sounds on the left side. A stat chest X-ray was ordered by the attending physician to evaluate the patient's lung expansion, which was completed at the bedside. The digital chest radiograph was labeled backwards. A left marker was mistakenly placed over the right side of the chest, resulting in an incorrect identification of a pleural effusion. The resident assigned to the case performed a brief examination and then interpreted the X-ray. The resident recommended doing a therapeutic thoracentesis, which was cleared and approved by her attending physician. Consent was obtained from the patient. Although a physical examination was performed by the resident, she based her localization of the pleural effusion mainly on the mislabeled radiology image. Therefore, when the resident performed the thoracentesis on the right side, she was only able to draw 1.5 mL of blood and air. She then realized that the thoracentesis was performed on the wrong side. In addition, according to the documentation obtained from the electronic health record, the primary RN failed to do a procedural timeout. Soon after the procedure, a chest X-ray was repeated. A correctly labeled follow-up chest X-ray showed a persistent moderate-sized pleural effusion on the left side. A second thoracentesis was done by the attending physician this time on the patient's left side. Thankfully, the patient remained stable with no complications from both insertion sites. So from my understanding, this case unfortunately represents an all-common occurrence due to the lack of communication, standardized workflows, and protocols. I'm just sharing this case with you because I feel like this case can strengthen our safety protocols, quality of care, and our entire organization as a whole. I want to just kind of identify the errors before we go ahead and discuss everything so we can figure out all the issues and the contributing factors. So the first error that I noticed was the mislabeled X-ray. The second, the misinterpretation of the X-ray. The third, failure to have a secondary verification of the site. And fourth, failure to perform a timeout. Is there anything else that I'm missing that you guys can identify in the case as far as errors?
I think you've identified the errors that took place well. You know, there were definitely some pieces of this puzzle missing, and then some that were just misplaced altogether. From a risk management point of view, one thing that really stood out to me and was kind of seemed to be the root of this issue was the initial X-ray, which was mislabeled and then in turn misread. Everyone's human. People make mistakes. However, making mistakes with lives is a very serious issue. And I wonder if there's a way that we could require some sort of dual imaging verification for any thoracentesis to avoid this problem in the future. We had an initial X-ray. The X-ray showed, a need for the thoracentesis, but it was mislabeled. If there was possibly a bedside ultrasound that could have been performed, or another form of imaging study to verify that it was on the correct side, I think that we would have found an error before it was, affected the patient and stated a near miss.
That's a great idea. I'm curious, is there a way that technology of digital radiograph can be automatically labeled to prevent mislabeling? Does anyone know? Or, because if not, then I agree with you, Joe, that a dual verification is needed.
Well, with digital radiography, I think it would have to be something that maybe a marker would be embedded into the X-ray table. However, for portable X-rays, we weren't able to do that. You would still have to place the X-ray fluororeflective plate beneath them, which has the marker, and that could be placed incorrectly as well with the wrong marker, because there's still a human error at that point. So I don't know if it would work, if it was in an X-ray room, but not for any sort of fluoroscopy or portable X-ray that we have to do.
I see.
So,
Tracy.
Joe? Oh, go ahead.
Oh, I just wanted to ask Tracy what her thoughts were as a clinical nurse leader.
As a clinical nurse leader for our med-surg unit, we're all nurses. Our primary goal is to be patient advocates, and their safety is our priority. No nurse wants to know that they've made an error, especially one that could be harmful to the patient. In regards to what modifications can be made for the timeout process, we could potentially look into the evidence-based practices that have been initiated through studies where there's a dual nurse to RN check, one to verbalize that they're reading the information, and the other nurse will be required to actually physically chart it in the computer or the paper chart, whichever the facility is using. In our case, we use a computer chart. As far as the consent, that could also be utilized as a dual nurse chart, dual nurse check, one to read and the one to verify that the paper indicated with the signed consent is actually for that patient. As far as the X-ray, the X-ray I forget what they're called. The plates, yes, the
The
plates that go behind the patient for imaging purposes. The nurse could also ask the technician who is placing the plates what indicator is listed on the plate itself. For the adults, it's automatically on the plate. For example, in the neonatal world, it's a small plate that's about the size of a quarter. So we could ask the nurse to physically ask the tech what side they're going to be placing it on. For patient safety features, we want our patients to feel comfortable and trust the healthcare professionals that are taking care of them, and that would definitely make the process for patient safety a lot easier. But as far as the modifications that we can do, at the moment, the only ones that I can think of right off the top of my head.
Let me see. And last but not least, Brenna, as a Nurse Quality Informatics Specialist, do you have any thoughts on this issue or suggestions?
I do. I did review all of the electronic records, and I think sometimes we rely too much on the electronics and not on our physical examination. I don't see where the resident actually assessed the patient's lung sounds. He didn't document this, and I'm just wondering, did the resident actually listen to the lung sounds? If so, can he document them in the chart? And also, why did he hear diminished lung sounds on the left side if he did? So maybe we can focus on more of the discussion. I think if he did really do a thorough examination, he would have seen that there was diminished lung sounds on the left side. Maybe this could have been prevented. I think maybe he too much on X-ray. And then I'm looking at the X-ray, and I'm just wondering, how can we prevent mistakes in radiology films?
Mm-hmm.
And how can we ensure timeouts are performed? And I'm looking at some different timeout checklists that we can complete in the DHRA prior to starting the procedure. And I think that if they're signed and verified with more than just the person filling out the checklist, maybe we can have a clinician verify it. It might cut down on some of the mistakes that we're experiencing. Also, if maybe the images were real time in the electronic health record instead of having a lag time, I noticed that sometimes that happens. Maybe the clinician can review it while they're doing the procedure, or prior to it. It could be part of the checklist. So that's just some ideas I have from my standpoint.
No, those are great ideas. Now, on our current electronic medical record, the timeout, it just consists of the time, like the nurse just notes the time there, right? Is there anything else there? Is there like a second?
I'm thinking maybe if we have it verified with another clinician, it could be a nurse, could be just the two people
like two
verifying it. Yeah, two different people. I think that would cut down on some errors.
Now, as a unit manager, I want to ensure that that there is effective communication between all staff, and I feel that we can establish standardized workflows to ensure that maybe that the nurse and the physician are present during invasive procedures, just to do the timeout. And then I also had another question in mind. I just felt like maybe the resident wasn't too confident in maybe reading the X-ray, because wouldn't there be like an aortic arch that he can identify in a chest X-ray that would indicate whether it's the left side or right side without needing the marker? Maybe that's something that we can also bring up to the attending physicians. Perhaps there needs to be some education towards that resident.
I think that's a great idea.
Yeah, And the only exception I could see is maybe if it's a complete whiteout and they aren't able to read that at all.
That's true. That's true. That's something. Okay, well, it looks like we all put in our input in. I just want to thank you all so much for all your input. You provided so much insight on this NEVER event. I like the fact that everyone kind of brought up the fact that we are all humans, therefore we are fallible. We all know that medical errors will still occur, but despite technology or implementation or procedures or protocols, I'm glad that we can minimize errors. I feel that this mishap can lead to positive ways for improvement in DHRA as well as learning for all staff. Therefore, I will be submitting this to the Quality Improvement Committee for review. Now, for a recap, I just wanted to go ahead and discuss some of the questions that we talked about today, and those are what types of additional verification needs to be adapted prior to performing a thoracentesis, some types of quality indicators that need to be addressed for a thoracentesis, modifications that are needed to ensure procedural timeout occurs, and a type of workflow or standardized process that DHRA can input in place to prevent radiology errors. Is there anything else anyone wants to add before this meeting is adjourned?
No, I do not. Thank you.
No, thank you.
Okay, Brenna?
Thank you. Now I think we're figuring out the problem here.
Okay, well, thank you, everyone. Have a good night.
Thank you. You too.